In neurogenic shock, there is hypotension, normal pulse rate, or bradycardia, and warm, dry skin, loss of sympathetic outflow. Treatment: the patient should lie flat with elevation of legs, IV crystallized solution as Ringer's lactate. Vasopressors may be prescribed. Exceptions to classic picture of shock: in cardiogenic and obstructive shock, neck veins are congested and central venous pressure is high, while in neurogenic shock, pulse is not rapid, and patient may even have bradycardia. And then we have the septic shock. Etiology: causative organisms such as gram-negative bacilli, the commonest, staphylococci, and candida. Predisposing factors: all conditions that suppress immunity, old age, diabetes, corticosteroids, chemotherapy, malignancy, AIDS. Source of gram-negative sepsis: peritonitis caused by perforated viscus, gangrenous bowel, or leaking anastomosis, cholangitis or genitourinary infections, infected central venous castor. Pathophysiology is divided into mediators cascade, microcirculation, cellular derangement, acid-base imbalance, individual systems and organs. Mediators cascade: dead bacteria liberate lipopolysaccharide from the cell wall of gram-negative bacilli, endotoxins. Endotoxins trigger complex immunological reactions. Macrophages and Kupffer cells of liver release cytokines such as interleukins, PAF, prostaglandins, tumor necrosis factor, and nitric oxide in huge amounts. Harmful effect on the microcirculation, particularly on capillary endothelium, occurs. Microcirculation: cytokines lead to arterial vasodilatation and AV shunts are opened, decreasing peripheral resistance. Capillaries are bypassed and oxygen delivery to the tissues is impaired. DIC due to sluggish capillary circulation and PAF activation. Cytokines lead to vascular endothelial damage, leakage of protein-rich fluid to the interstitial fluid, and edema. Cellular derangement: oxygen delivery is decreased because of maldistribution of blood, the main factor. Late pump, heart failure. Hypovolemia: oxygen uptake and utilization by cells is directly suppressed by toxins. The sequence of events that lead from hypoxia to cell death are the same as described under hypovolemic shock, but at faster rate. Acid-base imbalance: accumulation of lactic acid and renal failure lead to metabolic acidosis. The usual changes in ABGs are low pH, lactic acidosis; low oxygen, less than 70 mm mercury, respiratory distress, then failure; low carbon dioxide, hyperventilation; low bicarbonate, depleted buffers. Individual systems and organs, as in hypovolemic shock, in the part of multiple organ failure. Septic shock is the most lethal type. Despite the availability of powerful antibiotics, the incidences of septicemia and septic shock are increased due to developing resistant and virulent organisms, concentration of infected patients in ICU, more extensive operations in elderly and poor-risk patients, salvage of severely injured patients, growing population of patients who are immune suppressed by organ transplantation and chemotherapy. Clinical picture: we have comparison between hyperdynamic warm and hypodynamic cold. Hyperdynamic: diagnosis is difficult and high index of suspicion is required to detect cases at this early stage. Hypodynamic cold: if the previous stage is not treated efficiently, picture similar to hypovolemic shock with reduced cardiac output occurs. For the clinical picture, hyperdynamic phase is described as restlessness, confusion, fever more than 38 degrees Celsius, chills, patient is flushed with warm dry extremities, mild decrease in blood pressure, cardiac output is elevated, tachycardia, tachypnea, and oliguria. But for the clinical picture in hypodynamic phase, cold clammy skin, systolic blood pressure less than 90 mm mercury, tachycardia, tachypnea, oliguria, multiple organ failure starts at this stage. Septic shock is considered part of SIRS, the cascade of events, including mediators, release, and ending with translocation of bacteria, are common with other members of the syndrome, which are major trauma, major burn, acute pancreatitis, neglected hypovolemia. Diagnosis: helped by polymorph nuclear shift to the left, high lactate level in the blood, looking for a source of sepsis, repeated blood culture at the peak of fever, or culture from the septic focus to guide antibiotic treatment at a late stage. Treatment: as soon as possible in the ICU, support of different systems to maintain against multiple organ failure, fighting infection, monitoring, and additional measures. Monitoring as for hypovolemic shock. Additional measures: controlling blood pressure, blood sugar, prophylaxis against DVT by heparin, prophylaxis against peptic ulceration by PPIs, fighting infection, immediate recognition and early eradication of source of sepsis as huge abscess drainage or resection of gangrenous colon. Antibiotics start with multiple and broad-spectrum antibiotics. The results of culture insensitivity appears. In most cases, organisms are gram-negative bacilli. The most commonly used combination are cephalosporin, aminoglycoside, and metronidazole. Prognosis: mortality ranges from 25% to 90%. Death is due to late therapy initiation. And for the supporting of different systems, for the cardiovascular support, fluid replacement aim central venous pressure 10 to 12 cm water and PAWP 12 to 15 mm mercury. Prompt correction of fluid deficit is essential. Ringer's lactate is usually used. High quantities of fluids are often needed. The amount often exceeds 10 liters within few hours. Packed RBCs transfusion indicated with low hematocrit. Medications: in the persistent life-threatening hypertension, in spite of active treatment, inotropic drugs are given as dopamine and vasopressors as norepinephrine to keep the mean arterial blood pressure more than 65 mm mercury. In resistant cases, epinephrine or dobutamine. Respiratory support start with oxygen 100% for all types and later adjusted according to response. If the arterial oxygen is mildly decreased, oxygen by mask, but if oxygen decreases less than 60 mm mercury, endotracheal intubation and MV. Renal support: adequate volume replacement and dopamine improve renal blood flow. Hemodialysis in acute renal failure. Endocrinal shock. Etiology: patients with Addison's disease, patients receiving continuous cortisone if subjected to any stress as infection or surgery due to failure of cortisol release. Treatment of predisposing factors: saline infusion, IV hydrocortisone. Obstructive shock. Etiology: tension pneumothorax, cardiac tamponade, massive pulmonary embolism. Pathophysiology: reduced filling of the right side of the heart. Clinical picture: decreased cardiac output, increased jugular venous pressure and central venous pressure. Treatment of the cause: treatment of shock for hypovolemic shock, controlling hemorrhage, volume resuscitation. Cardiogenic PTCA, inotropic support. Septic: large volume saline, noradrenaline drip, eradication of infection by antibiotics. Obstructive shock, tension pneumothorax equals needed thoracotomy, massive pulmonary embolism, fibrinolysis, and pericardial tamponade, pericardiothesis. Surgical infections and antibiotics. Acute non-specific surgical infections, pathogenesis, interaction between an infectious agent and a susceptible host in the presence of closed unperfused space. The infectious agent, endogenous or exogenous. Endogenous: microflora in different areas of the body, skin, gram-positive organisms such as staphylococci, streptococci, cause infection of traumatic lacerations or surgical wounds. In GIT, aerobic and anaerobic organisms are found in the oropharynx, colon, and rectum. Exogenous agents within hospitals, the most important: hospital-acquired infections. Sources: other patients, staff members, and defects in sterilization. Host reaction: the host's immune mechanism include non-specific and specific immunity. Non-specific immunity: phagocytic leukocytes impaired by uncontrolled diabetes, corticosteroids, and malnutrition. Specific immunity: by specific antibodies produced on previous exposure to antigen, activation of T and B lymphocytes, impaired by immunosuppressive therapy and in AIDS patients. The closed space is natural spaces with narrow outlets such as gallbladder, appendix, diverticula, prone to become obstructed and infected. Complications: spread of infection, fistula and sinus, necrosis or gangrene, suppressed wound healing, and major sepsis. Spread of infection: direct, lymphatic, and bloodstream distant abscesses, byemic abscess. Lymphatic, as in strep and staph infections. Lymphangitis with red streaks in skin that travel to proximal lymph nodes. Direct, necrotizing fasciitis along unperfused subcutaneous and facial planes. Fistula and sinus, example: neglected perianal abscess leading to anal fistula, while pilonidal abscess, sinus tract. Major sepsis, SIRS, septic shock, and multiple organ failure. Etiology: release of antitoxin by gram-negative bacteria. Prognosis: related to age, general health, and number of affected organs. If one organ, usually lung or kidney, 70% recovery. 2 organs, 50%. More than or equal to 3 organs, worse prognosis. Bacteriology: we have staphylococci, streptococci, aerobic gram-negative bacilli, and anaerobic bacteria. Anaerobic bacteria, part of the normal flora of the skin and mucous membrane, mainly Peptostreptococci and gram-negative bacilli bacteroids. When the epithelial barrier is disrupted, they invade tissues and produce abscesses characterized by gas formation, tissue necrosis, foul-smelling discharge, entering bloodstream leading to septicemia. Aerobic cultures fail to grow these organisms, and infection usually follows operations on colon, oral cavity, or vagina. Aerobic gram-negative bacilli, such as E. coli, site in the intestinal tract of all human beings, non-pathogenic under ordinary conditions, affect most urinary tract infections, majority of abdominal suppurative lesion, alone or mixed infection, Klebsiella, special variety of encapsulated gram-negative bacilli, site in the respiratory tract, leading to fatal pneumonia in debilitated patients, Pseudomonas aeruginosa, difficult to eradicate, present in human feces in 20% of cases, recognized by its specific blue-green color of pus and its odor, Proteus vulgaris, UTI, common, and in wounds and burns as a component of mixed infection. Then we have the streptococci, gram-positive, which grow in chains, types non-hemolytic and hemolytic, virulent, more virulent than the site in the nasopharynx, mode of transmission by droplet infection and effect, spreading infections as cellulitis, lymphangitis, and erysipelas. Staphylococci, the commonest organism, gram-positive, site, live in skin, including sebaceous and sweat glands, in nostrils in about 25 to 50% of normal adults. Mechanism: produce coagulase enzyme, localization of infection, abscess formation, rather than spreading infection as boils, acute abscesses, and carbuncles. The commonest cause of osteomyelitis and infected surgical wounds. Some strains also produce penicillinase resistant to penicillin, MRSA, methicillin resistant, Staph aureus. Some of the most resistant bacteria, hospital-acquired infections, they are very serious. Most are sensitive to vancomycin, but we have vancomycin-resistant Staph aureus. Treatment: abscess, drainage of pus. Methods: incision and drainage, percutaneous drainage using needle aspiration or by placement of percutaneous fine catheter as in brain abscess to avoid damaging irreparable neural tissue, ultrasound or CT guided catheter insertions through tiny skin incision for intra-abdominal abscesses, spreading infections as cellulitis or erysipelas, antibiotics, excision indications, infected appendix, gas gangrene, necrotizing fasciitis, general supportive measures, examples, controlling diabetes, limb revascularization in cases of ischemia, and nutritional support. Diagnosis, clinical evaluation, lab studies, and imaging studies. Imaging studies, plain radiographs used for osteomyelitis, pulmonary infections, and subphrenic abscess, elevated immobile copula of the diaphragm, ultrasound, CT scan, and radionuclide scans, localized deep-seated infections. Laboratory studies, leukocytosis with shift to the left means pyogenic infection, inflammation markers as ESR and CRP, elevated with any inflammation non-specific but used to monitor progress of inflammation, bacterial culture and sensitivity for discharge, urine, or sputum. Patients shouldn't be on antibiotics for 3 days before taking any sample. Blood cultures, essential in serious infections, usually 3 blood samples taken from different veins over 24 hours. The blood is used for aerobic and anaerobic cultures. Clinical evaluation, constitutional symptoms, fahem, fever, anorexia, headache, malaise, and tachycardia. Severe cases with septicemia, dyspnea, and rigors. Locally, the inflamed area is painful, red, hot, and tender, and draining lymph nodes may be enlarged, painful, and tender. Surgical site infections, SSIs, definition: infections of the tissues, organs, or spaces exposed during the performance of an invasive surgical procedure. Contamination equals presence of microorganisms in a wound. When these organisms invade the tissues, they lead to infection. Classification: incisional, organs, and spaces. Spaces as subphrenic, pelvic, interloop abscesses. Incisional, whether superficial or deep. Superficial, limited to deep to the skin and subcutaneous tissues, while the deep involves musculoaponeurotic layers. Etiology: general host factors and local factors. General host factors: obesity, old age, anemia, malnutrition. Immune suppression as in diabetes, uremia, and malignancy. Immune suppressive drugs as corticosteroids and chemotherapy. Local factors: nature of operation. This is the most important. We have 4 classes. Poor skin preparation, defect in instruments sterilization, prolonged surgical procedures, improper surgical technique as leaving dead spaces, hematoma, too much use of diathermy, or rough handling of tissues, poor blood supply due to prolonged periods of hypotension and suture of tissues under tension, presence of foreign bodies or prosthetic material. Most SSIs are endogenous due to microorganisms from the patient. Infections deep to the deep fascia are difficult to recognize, has systemic signs of infections such as bacteremia, asymptomatic presence of bacteria, not multiplying in blood, usually harmless, causes dental work or UT instrumentation during infection, septicemia, presence of multiplying bacteria in blood, plus leukocytosis. Significance: severe infection, bacteria and their toxins or inflammatory mediators escape the control of immune system, enter blood, systemic response, chills, fever, pulmonary failure, and shock. Classification of the nature of operation: we have 4 classes according to resumed magnitude of the bacterial load at the time of surgery. We have clean wounds, clean contaminated, contaminated wounds, and finally dirty wounds. Clean wounds: elective non-traumatic wounds in which GIT or urinary or respiratory tracts are not entered. Risk of SSI is less than 2%, while clean contaminated class 2, elective surgery into the GIT, UTI, or respiratory tracts with no significant spillage. Risk of infection is from 2 to 5%. Contaminated wounds class 3, open accidental wounds encountered within 4 hours, gross spillage from the GIT, incision through inflamed, non-purulent tissues. Risk of infection 10 to 20%. Dirty wounds class 4, traumatic wounds more than 4 hours, purulent infection or necrotizing soft tissue infection, perforated viscous. Risk of infection is up to 40%. Clinical features: we have usually appears between 5th and 10th days post-operatively. Symptoms: general fahem, local, wound pain, and post-operative fever. The earliest features: signs, inspection, discharge from the wound. Wound is swollen, sutures dipping through the skin, tender, red, palpation, fluctuant areas or crepitus occasionally felt. Recommendations to minimize surgical site infections for the patient, for the surgeon, and prophylactic antibiotics. Prophylactic antibiotics indication: clean contaminated or contaminated surgery and in wounds where foreign material is implanted. Surgeon should have short nails, scrub properly, meticulous surgical technique by adequate homeostasis, gentle handling of tissue, avoid tight sutures or leaving dead space, delayed primary closure of heavily contaminated wounds. Patient: correct any predisposing factors such as controlling diabetes, stopping smoking, correction of nutritional deficiencies, avoid operations in patients with active infections if possible, clipping preferred or shaving the hairs just before skin incision, shaving tiny abrasions colonized with bacteria. So that's why clipping is more preferred than shaving. Prophylactic antibiotics should be given pre-operatively and sometimes during operation, and in the early post-operative period, antibiotic is given 1 hour before surgery. A booster dose may be given in a lengthy operation. Further doses depends on the degree of wound contamination. Duration of administration rarely exceeds 1 day. First generation cephalosporin, cefazolin, is usually used, but each hospital has an infection control committee which recommend an antibiotic according to its prevalent microorganism. Treatment: liberal drainage, open the wound by removal of skin stitches. Antibiotics used in invasive infections guided by culture and sensitivity test. Trace and correct possible sources of hospital-acquired infection. Cellulitis definition: invasive, non-suppurative infection of the loose connective tissue. Etiology: causative organism, gram-positive, staphylococci, streptococci, but streptococci is the most common. Staphylococci occasionally into the superficial skin sutures. Mode of transmission: trivial trauma, scratch or a prick. Clinical picture: general, moderate to high fever. Local, affected area is red or reddish, indurated, hot and painful. Spreads rapidly and the advancing edge is ill-defined. Lymphatic spread: red streaks of lymphangitis and enlarged tender regional lymph nodes. Treatment: antibiotics, penicillin group, warm packs, rest and elevation of the affected part. If no response within 48 hours, abscess has developed or resistant organisms as staphylococci are involved. Although we have increased polymorph nuclear cells, but we have no pus formation. Erysipelas. Definition: rapidly spreading non-suppurative inflammation of skin lymphatics. Causative organism: specific strain of hemolytic streptococci. Mode of transmission: through minute scratch or abrasion. Clinical features: general, fever, malaise, and loss of appetite. Local, similar to cellulitis, but there are some differences. The skin is rose pink. Edge is well defined, slightly raised, and often shows minute vesicles just beyond the spreading margin. There may be islets of inflammation beyond the spreading margin, separated from the main area by apparently normal skin. Complications: cavernous sinus thrombosis in facial erysipelas. Septicemia: recurrent erysipelas may block lymphatics, leading to elephantiasis. Treatment: like cellulitis, by antibiotics, mainly penicillin, commonly given IV. Boil or furuncle. Definition: staph cocci infection of a hairy follicle. Site: in an hairy area, common in face, neck, and axilla. Predisposing factors: diabetes, common. Recurrent boils. Lack of personal hygiene. Clinical features: small, painful, indurated swelling, which is hot, red, and very tender. Often necrosis of the central part occurs and discharged together with small bead of pus. Treatment: antibiotics, effective against staphylococci. Warm foments overlying skin necrosis, leading to pus and sloughing. Scape: painting surrounding skin with an antiseptic. Prevent infections of neighboring hair follicles. Early treatment: resolve without suppuration. Blind boil. Hydradenitis suppurativa hydradenitis. Definition: mixed staph and strep infection of apocrine sweat glands in the perineum or axilla. Clinical picture: multiple abscesses and pus discharging sinuses. Prognosis: difficult to eradicate and usually progresses to chronicity with considerable fibrous tissue reaction in the perineum, misdiagnosed as multiple anal fistulae. Differentiated by examination and leading to absence of internal anal openings. Treatment: drainage of abscesses followed by careful hygiene, painting with disinfectants and antifungal, or excision of apocrine sweat-bearing skin followed by skin grafting. Carbuncle: Staphylococci aureus infection of subcutaneous tissue leading to infective gangrene. Predisposing factors: immunocompromised as diabetics, common. Pathology: site mainly in the face, nape of the neck, and the back. Pathogenesis usually starts in a hair follicle, extending to subcutaneous fat. Other hair follicles get the infection. Multiple areas of necrosis and thrombosis of blood vessels, leading to slowing of the skin, patches, and sinus formation. Clinical features: general, severe toxemia. Local, starts as painful induration of the skin and subcutaneous tissues. Skin is red. Swelling enlarges. Central part becomes soft. No fluctuation. Multiple areas of skin thin out and separate, leading to multiple sinuses that trickles out small amount of thin pus. Complications: septicemia, local spread of infection, cellulitis, and lymphangitis. Carbuncles of dangerous areas of the face lead to cavernous sinus thrombosis. Treatment: antibiotics against resistant staphylococci, culture and sensitivity of the discharge, controlling diabetes if present. If no response to conservative treatment, surgical excision of sloughs. Acute abscess. Definition: localized suppurative inflammation. Etiology: causative organism, pyogenic organism, staphylococci the commonest. Produce coagulase enzyme, localize acute inflammatory processes. Route of infection: direct, local extension, lymphatic and blood. Direct, through wounds, scratches, abrasions, or along natural passages such as lactiferous ducts. Local extension: from adjacent focus as osteomyelitis of the jaw, from infected tooth. Lymphatic: from septic focus, lymphatics, regional lymph nodes. Blood: organisms gaining access into circulation as in bacteremia or pyemia, lodge in distant tissues. Abscesses as pyemic liver and lung abscesses. Pathology: abscess consists of 3 zones. Central zone or zone of coagulative necrosis separates from surrounding tissues and forms a slough, liquefied by enzymes of dead WCs, YBCs, leading to pus. Intermediate zone of granulation tissue, protective layer against bacterial spread and their toxins. Peripheral zone of acute inflammation, fades gradually into healthy surrounding tissues. Fate: pointing and rupture, the commonest. Spread of infection, chronicity. Mechanism: dense fibrous tissue reaction forms around, leading to formation of a mass with little inflammatory reaction around. Etiology: prolonged course of antibiotics or inadequate drainage. Clinical picture: symptoms: painful tender swelling. Signs: general, fahem, and tachycardia. Local: the covering skin is red and edematous. The draining lymph nodes are usually enlarged and tender. Pus formation is indicated by throbbing, pain, hectic fever, covering skin shows pitting edema, inflammatory reaction becomes localized, there's shooting leukocytosis with shift to the left, fluctuation shown in subcutaneous abscess. Treatment: once pus forms, means free drainage. Incision and drainage, the standard method. The incision done over the pointing part of the abscess should be dependent, otherwise a counter incision over the dependent area. Loculi inside the abscess are broken. Ensure adequate drainage. Rubber drain or a wick of gauze is left protruding from the abscess cavity and specimen of pus is sent for culture and sensitivity. Adequate free drainage is usually enough for most abscesses. Antibiotics are required only in overwhelming infections. Immunocompromised patients. Ultrasound or CT-guided aspiration drainage indications. Deep-seated collections as intraperitoneal abscess. Fluctuation is absent or difficult to elicit in deep abscesses, perinephric or gluteal abscess, abscesses covered by strong fascia, parotid abscess, breast abscesses, as the normal breast tissue gives false sense of fluctuation. So we don't wait for fluctuation in these areas as it is a late sign. 5Ps: perinephric, buttocks, breast, parotid, and pulp space. Necrotizing fasciitis or non-clostridial necrotizing infection. Necrotizing fasciitis of the perineum or scrotum is known as Fournier's gangrene. At surgery, the finding of edematous, dull, gray fascia and subcutaneous tissue with visible thrombi in penetrating vessels confirm the diagnosis. The definition of necrotizing fasciitis: diffuse non-suppurative infection extending to deep fascia. Etiology: causative organism, mixed microbial flora, microaerophilic streptococci, staphylococci, gram-negative bacteria, and anaerobes, especially peptostreptococci and bacteroids. Predisposing factors: immunocompromised patients as diabetics and with malignant neoplasms. Mode of transmission: through puncture wound, leg ulcer, or surgical wound. Pathology: the infectious process spreads along the facial planes, leading to infectious thrombosis of its vessels. Superficial skin necrosis, resembling ischemic vascular or clostridial gangrene. The first sign of skin death is hemorrhagic bullae. Facial and subcutaneous fat necrosis involves an area wider than the skin. Clinical picture: general, the patient is alert and fully conscious. There are manifestations of toxemia with fever and tachycardia. Local inspection: skin shows hemorrhagic bullae and necrosis surrounded by edema and inflammatory signs. Palpation: crepitus occasionally, and skin may be anesthetic. Investigations: gram-stain smears and cultures. Mixed infection. Prevention: adequate debridement, blood loss replacement, antibiotics for contaminated wounds. Treatment: surgical treatment under anesthesia. Debridement with removal of necrotic skin and fascia. Muscles are usually healthy and the limb can be salvaged. Antibiotics: penicillin 20 to 40 million units per day, IV together with gentamicin 5 mg per kilo per day, or amikacin 15 mg per kilo per day. Material is sent for smears and culture and sensitivity before treatment. Blood transfusion, nutritional support, and controlling diabetes. Prognosis: in many cases, the diagnosis is missed. In elderly patients, it's likely to have fatal outcome. And this concludes our part for the infection.